So, you deal with the vents all the time, and there's often not a therapist at bedside all the time. So many hospitals, like I used to work in Nashville, the ICU nurses took the vent all the time. And it's really a very easy tool. So the reason for mechanical ventilation, why do we put a person on a vent? And number one, of course, hypoxemic respiratory failure. That'd be pulmonary edema or ARDS. That you can't oxygenate the person. You got up to 100% O2, and they're sat still 85 or 86 or 82. So hypoxemic respiratory failure is probably one of the most common reasons for mechanical ventilation. Then hypercapnic respiratory failure. We see this all the time, either COPD patients, obesity, hypoventilation. We see this, and overdose. We see a lot of overdose. Now, overdose often falls in two different categories. Often we see also a group of people that can't protect their airway. We see our stroke patients frequently. They can't swallow. They can't swallow their saliva. They fill up the airway. Or overdose patients, they're not awake enough. So that overdose patients fall in two categories. One is because they have a neuromuscular problem. They're not breathing. Plus they're comatose, so that they're not really protecting their airway. And a fourth group of people sometimes gets intubated. They're sat maybe perfectly good, but they're working so hard, like patients that come in septic shock. Normally, less than 5% of your cardiac output goes out towards your respiratory muscle. A patient in septic shock, as much as 35% of their cardiac output may be going to their breathing because they're acidotic, they're working very hard. So if you let a septic person who already has low blood pressure, 30% of their cardiac output going toward their breathing, then their brain, their kidneys not getting any blood. And so this has been a very common practice that very septic patients that working hard to breathe, even if their SAT's good, you put them on a vent so that the work of breathing goes down, so more of your cardiac output going toward your respiratory, from the respiratory to your renal splanchnic bed to your brain and so forth. So these are the four categories for which we use mechanical ventilation. Am I talking too fast? Okay. So causes of hypercapnia, again, either the person's making too much carbon dioxide, which is relatively rare, like we rarely ever see thyrotoxic patients. Their metabolic process is so high they're making too much. Most of the time, hypercapnia is because of hypoventilation. That means overdose, CNS depression, neuromuscular problems, stroke, and stuff like that. And I'll leave these presentations in this computer that way if anybody wants to copy. This is not my doing. This is from a textbook of physiology, so it really covers all the bases. The causes of hypercapnia, most of the time hypercapnia because they're hyperventilating or they have mismatch, like severe COPD patients where the alveolar air and pulmonary capillary blood don't see each other, so the CO2 builds up and you have hypercapnia. So cause of hypoxia. Most of the time, hypoxia we see in patients that have alveoli that are flooded with fluid, either flooded with fluid from heart failure or flooded with fluid that are exudative fluid, like in ARDS. And then there's a third category we see not infrequently here, negative pressure pulmonary edema, like somebody had anesthesia, had surgery, post-op, they're extubated, they were not waking up, their airway closes up, they work very hard to breathe, they generate such high negative intrathoracic pressure, the capillaries leak and all this fluid flood into alveoli. You see this at least once or twice a month. We see patients like this. MSIC, we had one person like that on Friday. Perfectly fine, clear chest x-ray, normal SAT, goes to surgery, and then post-op, they're extubated, they go into pulmonary edema. Generally, anesthesia uses this term, negative pressure pulmonary edema, and it sort of has become the accepted term. So basically, almost most hypoxia is going to be for alveoli that are flooded with fluid, heart failure or ARDS or negative pressure pulmonary edema. Rarely ever we see hypoxia like MICU bed 10. The person has pulmonary fibrosis, interstitial lung disease. Normally, where the oxygen transfer happens between the alveolar air and pulmonary capillary, that gap is a couple of microns. And when a person has pulmonary fibrosis, that fibrotic tissue, as it grows, that gap becomes much thicker. So the amount of time RBC going through the pulmonary capillary may be 0.6 or 0.8 seconds, not enough time for the oxygen to transfer into the alveolar air. So pulmonary fibrosis, another reason for us to see hypoxia, but we don't see that many pulmonary fibrosis patients. Majority reason for hypoxia is the alveoli are flooded. And then there is few other reasons. Cyanide poisoning. We don't see that much cyanide poisoning. Cyanide poisoning basically is not really true hypoxia. It's hypoxia at the tissue level because cyanide paralyzes or permanently binds to cytochrome. Cytochrome is a group of enzymes that carry oxygen into mitochondria, so that the person would behave like they're cyanotic, they're hypoxic, but their PO2 may be okay because their oxygen is just not going into the mitochondria. And then you see shunt, right to left shunt, like person who has cyanotic heart disease, or in theory, as much as 5 to 10% of population may have a septal defect. And then you put them on a ventilator and add PEEP, and then that shunt can reverse and you can see hypoxia. But in all reality, a person's hypoxic, the person most likely has ARDS, pneumonia, or CHF, or heart failure, pulmonary edema, and these are the cause of hypoxia. So what are our goals of mechanical ventilation? The goals of mechanical ventilation is just to enough. Mechanical ventilation does not cure the underlying disease. Multiple studies have been done. Whenever we use a ventilator to make X-ray look pretty or think we're going to make the disease get better, there is higher mortality. Multiple studies, and every mode of ventilation, including low PEEP, high PEEP, tidal volume, and all of that. So the goal of the mechanical ventilation is to keep the person alive and minimize damage. And that means you don't have to make the PCO2 normal. We only have to do lower the PCO2 enough where pH is around 725. This is from animal studies. The pH of 725 is about where you don't have hemodynamic consequence. Like a person has high PCO2 and pH 705, if that person's hypotensive, your pressures, the level of fat and stuff, may not work as well. So our goal is to get the pH close to 725. And that means with the pH 725, if their PCO2 85, perfectly fine. We don't have to make the PCO2 normal. All we're doing, keeping the person alive and minimizing damage. And in terms of oxygenation, a SAT of 85 to 88 is more than plenty, because in the mitochondria, PO2 is 1. So we don't, when the SAT drops, we panic. Really, there is nothing scientific that to say that SAT of 75 or 80 for 5 minutes is going to kill a person or is going to change their future. Only thing, we have to remember the brain needs a continual supply of oxygen, so that's our primary goal. So SAT of 88 is more than plenty. So whenever we try to make the SAT 100, and in that process we increase pressure, increase PEEP or tidal volume or whatever, that can potentially cause damage. Because see, if you look at whenever you're putting a person on a vent, most of these people have alveoli that are inflamed. They have ARDS, that means the alveoli are inflamed. And so if we use too much PEEP, too much pressure, too much tidal volume, we may make their blood gas look pretty, but in that process, we're causing more stretch, we're fracturing more alveoli. Technically, we are adding to their measure, we're adding to that person's lung damage by trying to make their blood gas look normal. Because normal is not the goal. The goal is to keep the person alive until they get better. I think I've said it 3 or 4 times already. So initial setting, really a ventilator is easy, as easy as playing Nintendo 64. A 5-year-old can play it. So if you just get over the fear, look at this, all of you guys can manage a vent pretty fine, because you're ICU nurse, you're already genetically superior breed of people. So, so initial setting, 5 to 10 cc's per kilo of tidal volume. So the things that you said, tidal volume. Tidal volume means how much air the machine is going to give to that person's lung. So if you pick 6 or 7 cc's per kilo, you cannot go wrong. And that's why most of the time is 500 cc's are picked, because most people around here between 80 to 100 kilos or 110 kilos, so, but 5 to 7 cc's, or you can just pick one number, 6 cc's per kilo is the tidal volume. Rate, 10 to 15 times a minute. So tidal volume rate, and our goal is normally a healthy person A man may breathe 5 liters per minute. A woman maybe 3.5 or 4 liters per minute. So 2 to 3 times of that is more than plenty, because if we're putting a person on a ventilator, we are expecting that the person's, there should be reason to believe that the person's lungs are not healthy. That means the lungs are not as efficient, so that 4 or 5 liters may not be enough. So if you start with 10 liters, you can't go wrong. That means 5 cc's per kilo, or 6 or 7 cc's per kilo, no more than 10, because there have been studies, and I'll come to that in a minute, even more than 8 or 9 or 10 could be harmful. So 7 cc's per kilo. So you start with an average sized person, you give a tidal volume of 500 cc's, a rate of 15 to 20 is plenty, even as low as 10, depending on if they have COPD. So that, if you look at a rate of 20 and 500 cc's, is 10 liters. In a woman, you can be at 6 or 7 liters. So that's for ventilation, tidal volume multiplied by rate. What it is, that much air is going in and that much air is coming out, get the carbon dioxide out. So rate and tidal volume, the main purpose of this is minute volume. So rate times tidal volume is minute volume, and the minute volume, this is for ventilation. For oxygenation, O2, FiO2, you start at 100% when you put a person on a vent, but the goal is to get that FiO2 down as soon as possible or as quickly as possible, because more oxygen has more free radical, and more free radical can cause added damage to a lung that's already inflamed. Now, the 100% O2 is been conventional. Some of the institutions that have people smarter than us are starting at 98% O2. The idea is that if you start at 100% O2, by the time you get everything settled, and the blood gases may have been 2 hours, so oxygen diffuses. The nitrogen stays in the alveoli. So nitrogen is what holds the alveoli open. It's like the stent for the alveoli. That's why God created air with not 100% oxygen. There's air. So if you start with 98% O2, that 2% nitrogen may be all it takes to hold out, to prevent more atelectasis. Otherwise, this is theoretical. This is theoretical based on animal model, but we can start at 100 or 98% O2 and PEEP, 5 to 10 of PEEP, depending on what's the person's problem. And that's all the setting there is up front. So tidal volume, rate, FiO2, and PEEP. And then we get a blood gas, and then we're going to go to the next stage. And now our goal is to keep saturation at least about 88% or so. Some people like 90%. Cardiologists like mid-90s. There is no science that mid-90s any better than 88 for heart, brain, kidney, or anybody else, but you have to have peace and harmony. So suppose 92%. So that's where the PEEP comes into play. If you are 100%, and if you are, PEEP of 5, setting 87, you ramp up the PEEP. The idea that increasing the PEEP is helpful because what the PEEP does basically, when a person's breathing out, if the PEEP is at 10, when the pressure is at 10, the valve cuts off. That means the alveoli never gets a chance to completely collapse. That way the alveoli stays open at all times. That improves gas exchange, that improves oxygenation. Going to a PEEP over 12.5 or 15, one needs to think about it, because once you have a PEEP of 15, your mean intrathoracic pressure may be higher than your CVP. So you may be making the person's saturation better, but true oxygen delivery may be going down, because you may be looking at a SAT of 95 as opposed to 87, but your stroke volume may have gone down by 20, 30%. So the true amount of oxygen that going forward may be less. So once somebody has decided their PEEP is at 15, you have to look at other physiological parameters like, urine output, blood pressure, heart rate, maybe a CVP, maybe, and so forth. So this is all there is: tidal volume, rate, FiO2, and PEEP. And then we look at a few things. IE ratio. IE ratio is, normally it takes more time to breathe out than to breathe in. And so the ventilator also has this alarms on the side. We should have brought in a vent. I'm sorry, maybe we can do it another morning. But so I to E ratio, we need to give twice as much time to breathe out than to breathe in. So these are the secondary things. Once we've set up tidal volume, rate, FiO2, and PEEP, then we look at what's their I to E ratio. And there is a simple button that can help you change I to E ratio. And then we look at two other things, peak and plateau pressure. You see the vent alarms all the time because the peak pressure is high. So what is the peak pressure alarm is we're giving 500 cc's of air or 400 or 600 cc's of air. And now the air is going down the airway. The airway is tight. The same amount of air is going to generate higher pressure. So peak pressure is a reflection of their airway. Peak pressure is a reflection of the airway. If the peak pressure is high, that means the airway is tight. The person needs suctioning. They probably has mucus or needs a breathing treatment. They may be bronchoconstricted or they're biting on the tube. Generally, these are your simple 99% of the times, suction, biting on the tube, or needs a breathing treatment if the peak pressure is high. So if there's a peak pressure it's high, then it's an airway problem. Plateau pressure. Plateau pressure, you actually have to press a button to find out plateau pressure. The plateau pressure is high. Plateau pressure, peak pressure, the machine's measuring the pressure as the air comes in, so it's dynamic. So you're measuring the resistance of the airway. Plateau pressure, patient breathes in, you hold the button. So the lung is completely inflated, no air is going in and out, and that's when you see what's the interthoracic pressure. And that's a reflection of the lung. So if the lung is stiff, the person has ARDS, the plateau pressure is high. You'll see in the respiratory chart, they chart plateau pressure. Plateau pressure more than 30 is supposed to have bad outcome. In fact, it's part of our sepsis bundle that we should look at the plateau pressure, try to keep the plateau pressure less than 30 or even lower than that. So peak and plateau pressure, these are secondary things, but and this actually explains that better. This is copied from a 1959 book, so I'll leave this here if anybody's interested. You may not be interested in it. So we talked about this already. So the modes of mechanical ventilation, there's two modes 99% of the hospital uses. We think we're very smart, so we use all these other modes, but nobody's ever proven that they're any better than these two modes, SIMV and CMV. So let's go to CMV first. This is the #1 mode. Any hospital in America, if you go to work, a patient gets put on a vent, the first mode is CMV. CMV means controlled mechanical ventilation. That means you set up that tile volume, rate, PEEP, and oxygen, and nothing else. And in a CMV mode, suppose you set up a rate of 15. That's giving a person 7 liters of minute ventilation, where the person's lung is inefficient or septic, they have a high minute volume, so the person is breathing 25 times a minute. Those machine breath 15 times, and 10 more breaths, the patient's breathing on top of the ventilator breath. Patient has to do minimal work to get those extra breaths. That means on a CMV mode, the work of breathing is the least. That way, whatever vent setting we set up, we don't know up front what is the right amount of air or ventilation the person needs per minute. If the patient needs more, the machine is going to provide that. Every time patient makes an effort to take a breath, that effort, there is a button called trigger. All you have to do, the patient has to generate 2, 3, or 4 liters per second negative flow, and the machine gives the whole 500 cc total volume. So CMV almost everywhere is the first mode immediately after intubation. In CMV mode, there is no pressure support, and I'm going to come back to that. CMV mode, all you have rate, tile volume, PEEP, and FiO2. And if you set up a certain rate and the patient needs more, patient gets it, no questions asked. The person has to just generate just a little effort to breathe. So that's SIMV mode. That's CMV mode. The upside of the CMV mode, very little work of breathing. So if somebody's sick and hypotensive, you put them on a vent. The best thing is to not have to make the person work hard and just minimal amount of effort. Patient physiologically, whatever the person needs, person's going to get. The downside of that is CMV mode. You can win. Like suppose 2 days down the line, the patient's better, their COPD or pneumonia, whatever is better, and we want to win. We can turn the rate down to 2, but rate of 2 and rate of 20 is same, because even at a rate of 2, if the person breathes 20 times a minute, the other 18 breaths, the machine's going to give the whole 500 cc's of air no matter what. That means we can say it's CMV mode and rate of 2 is no different than rate of 20. Does it make sense? Because we're not letting the person do any breathing. And let me come back to SIMV, then we'll go back to CMV. So in SIMV mode, it's called synchronized mandatory breath. That means in SIMV mode, same thing, you have rate, tidal volume, PEEP, and O2. But in SIMV mode, suppose you pick a rate of 15 and the patient is breathing 20 times a minute. That means those other 5 breaths, the person has to make an effort to breathe. And that's when you add the pressure support. So suppose somebody is coming in COPD, you do not want to make the person so comfortable that they're going to have a hard time winning. So you want to start on a SIMV mode. Or oftentimes from CMV, after first few hours, the person's stable. From CMV, you go to SIMV. On SIMV mode, you have to add pressure support. And that is for those extra breaths. So suppose your machine is set at a rate of 10. Patient's breathing 20 times a minute. And you'll see that rate of 10, if your tidal volume is set at 500, 400, 600, 10 times a minute, the person's getting that 4, 5, or 600 cc's of air. But the patient may be breathing 20 times a minute. Those other 10 times, you're going to add, that's why there's pressure support on SIMV mode. So the pressure support, what it does, every time the machine senses this person is taking an extra breath on top of the rate of 10 or rate of 5 or rate of 15 that has been set up, the pressure support is flow augmentation. Basically, increase the pressure, makes it easy to breathe. So what you do whenever you go to SIMV, on top of rate and tidal volume, you search pressure support. Most of the time, the patient's pressure support at 10. And you'll see on the machine it says spontaneous tidal volume. So if it's 600, then you know a pressure support of 10 is good enough. If it's 200, you know a pressure support of 10 is not good enough. You increase the pressure support, the spontaneous tidal volume goes up. Does it make sense? So we normally start with the CMV mode where all the work is done by the machine. As soon as the patient's stable, from CMV, we go to SIMV. SIMV is same as CMV, except for in SIMV mode, you add pressure support and you can wean. So then we start to cut back on their rate of ventilator. Our goal eventually is to get the person extubated. As soon as the person's starting to get better, you switch to SIMV, and weaning means you wean their O2. Your goal is to get to less than 50% as soon as possible. And your goal also is to cut back on the rate. As you cut the rate, you see patients breathing more and more spontaneous breath, and those spontaneous breaths are augmented by a pressure support. As you wean, at some point, you go from rate of say 20 to 10 to 8 to 5 to 2 to 0. As you go to rate of 0, then you are on a pressure support mode. That's when you are on CPAP and pressure support. CPAP is nothing but PEEP. So we started on SIMV where all the breathing was done by the machine. Then we went to SIMV where the patient is doing some breathing. And that is augmented by pressure support because as we put a person on a ventilator, we can't expect the person to breathe through all of the circuit without some help. So we give them pressure support of 5, 10, 15, or 20, whatever it takes. And we gradually cut down on our rate. As we cutting down on the rate, as we go down to rate of 0, basically, then we went from SIMV mode to CPAP and pressure support or pressure support ventilation. And at that point, the person's only on pressure support and a PEEP. PEEP is same as CPAP. And that is something we try to achieve as soon as possible. And you do this all the time. You're constantly winning the person. The goal of winning to go down to CPAP and pressure support. So as we go to CPAP and pressure support, then basically there's only one variable we're looking at. We're looking at that pressure support. As the person wins, our goal is to get the pressure support down to 5, PEEP down to 5. And that's basically what is spontaneous breathing trial that we do every morning. A spontaneous breathing trial is basically same as CPAP at 5 and pressure support at 5. And if they're breathing okay on CPAP at 5, pressure support at 5, generally the next step is extubation. So that's sort of it goes through. So here it goes through all of those things, but SIMV, CMV, and pressure support. But ultimately, so we start in CMV, go to SIMV, and go to CPAP and pressure support, and then we extubate. Now, there is a few kicks here. I mean, suppose you put a person on a vent, and he's still having trouble oxygenating. Then you increase your PEEP, and you try not to increase your PEEP to more than 15. And these are really the modes of ventilation. Now, in terms of troubleshooting, this page covers everything. If your vent is alarming, You could be smarter than a respiratory therapist if you just follow this. Patient having trouble breathing, check what their peak pressure is. Peak pressure is decreased, there is a leak in the circuit somewhere. If the peak pressure is increased, then the person check the plateau pressure. There's a button you press, hold down, called inspiratory hold. So if your peak pressure is high and your plateau pressure is high, that means there is one of those things, autopeep, pneumothorax. If peak pressure and plateau pressure, they're both high, something bad is happening. That person needs some attention, needs an X-ray, and is going to be one of those things. If the peak pressure is high, but the plateau pressure is not high, that means it's purely an airway resistance problem. Peak pressure is dynamic compliance of the airways. So if the peak pressure is high and the plateau pressure is not high, that means the problem is not in the lung, problem is in the airway. They're biting the tube, their secretion needs to be suctioned, or the patient has bronchoconstriction, needs a breathing treatment. And if the patient's in distress, peak pressure and plateau pressure, nothing is in a change, then the problem is somewhere else. Either they have a PE, or they have anxiety or something else back up there. So this covers everything that can. If the vent is alarming, if you do this, you're going to do everything a respiratory therapist does, maybe even more. I mean, and that covers. This is again from a really good textbook. I keep in my. I got one of those things in the phone, and that way you kind of think about it, look at it, and it covers all of it. So that's number one, troubleshooting, and then. Are we out of time? Okay. So then, fortunately, unfortunately, we see a lot of patients on other modes called APRV. You'll not see that anywhere else, 2 or 3 hospitals, because there are, when you have really sick persons, sometimes you can't give enough PEEP to get their SAT up to a decent range. So the difference between APRV, and SIMV is basically, the idea is that if oxygenation failure generally in people that have really, really bad ARDS, that you've given a PEEP to 15 and you can't get their oxygenation high enough, then we use APRV. APRV is basically, normally when you're ventilating a patient, you're holding the alveoli open for a very fraction of the respiratory cycle. In APRV, see, you have a P high and a T high. You're holding the alveoli open for 3, 4, 5, 6 seconds. So by holding the alveoli open for that long, you're basically squeezing some of this water out of the alveoli, making oxygenation better. So APRV is a mode. It's used only for people that have difficulty oxygenating, because we've never proven that APRV is better than just a regular mode. So we don't go to APRV just for the sake of going to APRV, because it's best not to subject people to things that have never been proven any better. Only time we go to APRV when we're having trouble oxygenating people. And that means mostly, almost always, it's ARDS patient. So in APRV, you pick a P high, which is same as PEEP, and a T high. So basically, you're giving PEEP of 25 or 30 or 35, and you're holding for 3, 4, or 5 seconds. And the idea is that by holding it open for that long, you can get some of that exudative fluid out of the alveoli. That means the gap between the alveolar air and the capillary blood becomes even smaller, then you have better oxygen transfer. And that's basically what is APRV. If we have time, I can switch to a different presentation. But this is what your APRV setting is. And which is basically, again, we talked about peak and plateau pressure, right? So if somebody's having trouble oxygenating, then you go into APRV. All there is, again, plateau pressure we talked about, holding, at the end of inspiration, holding a button to hold the respiration, so you're checking the compliance of the lung and not the compliance of the airway. So plateau pressure plus 5 would be your starting P high. And starting T high, if you start at 3 seconds, you can't go wrong. And that's all there is, really. P high is plateau pressure plus 5. And if you know that, you know more than all the residents. Plateau pressure plus 5 is your P high. And a P low is always, so 4 things on APRV: P high, P low. P low is always 0. P high is plateau pressure plus 5. T high 3.5 seconds, and T low about 0.7 seconds. And then you go from there, you know. I think we covered all of this here. Yes. Huh? T-low always you start at 0 because you're never going to 0. You're just creating a pressure gradient. If it's you can put a T-low of 5. All that will do is just basically the idea is you're holding the alveoli open for 3 or 4 seconds or 5 seconds, and then in letting go for a fraction of the time, maybe 0.7 or 0.8 seconds, you're letting but part of the air out to ventilate, and then you're reinflating. So you're never completely letting the alveoli completely go down. So T low is 0.7 or 0.8 seconds, and then you adjust based on your blood gas and based on your graphics. P low is always 0, but doesn't have to be always 0. But P high is the important number is P high, plateau pressure plus 5. Now, there's one other thing you're seeing a lot, and this proning. That is part of ventilation now. We've done this for ages. The idea is that a person has ARDS, all this exudate that comes out by gravity goes to the bottom. If you look at a person laying on their back, a big chunk of their lung is on the bottom. So all that goes down there. So then when you're putting all the PEEP and all of the air is going to the front or the anterior part of the lung, but most of the blood flow is in the bottom part of the lung, and those alveoli are filled with exudate. So there's mismatch. The blood is going here, the air is going here. If you put a person on the face, the way the chest is made, there's a lot less lung in the front. That means the same exudate, you're pushing them to the front. That means to a part of lung that is much less in contact space to the bed, if you look at the way the chest is made. So that way you have all the back of the lung clears up. You have much better match between oxygenation and ventilation. So there is a big trial that was in the journal in June. It looked like you can change mortality by something like 20%. We've done 11 patients so far, and they all do good. I mean, you can see there was this malaria patient. Her stat was 88 on 100% PEEP-10. 6 hours after proning, her PO2 went to 276. But not only that, so you can oxygenate the person better without giving high PEEP. And because oftentimes we use APRV, we're making their stat better, but deep down, we've never proven in a big trial that it's not harmful. Or in the long run, it's not to make the X-ray look pretty, it's not to make the stat better. Are they going home alive more often? So this, by turning the person upside down, there's a big trial that shows much better chance that the person is going to go home alive. 10 or 11 patients so far, everybody's sat immediately improves. Within a few hours, the saturation improves. So that's something that I think is going to happen. There's a video in a computer, at least in one computer in every unit, for us to kind of look at how to do the turning. Neuro did the first patient, they did great. I mean, she did fantastic. And then since then, I think almost every unit has done 1 or 2. Questions?
I have a question. Mm-hmm. What causes pulmonary fibrosis?
If I knew, I'd be a very rich man. But nobody knows. I mean, classic pulmonary fibrosis, nobody knows. That's why really there's no treatment. I mean, we use steroid and mucomyst and look like that actually increases mortality. There's no treatment because we don't know what causes it.
What about for ARDS? Has there been any research that's come out? Because I know before they tried to treat ARDS, but other than using APRV, it's increased mortality. Has anything come out since to treat for the inflammation?
Well, the ARDS, ultimately the idea is to treat the underlying problem, keep the person alive. By proning, turning upside down, you can keep the person alive with less oxygen and less PEEP. So that possibly that's what translates into the outcome of that one study where you see significantly better outcome in terms of mortality and going home and stuff like that. But other than that, we use various things. We use oscillation, we use inhaled nitric oxide, all that kind of stuff. you do this out of desperation, because if you can't oxygenate a person, you got to keep him alive, you know. And then all else failed. Now we have ECMO service. Dr. Smith, Dr. Mahia is trained in it. I think they've used a couple of patients, but if you look at it, most of the time it's possible to oxygenate a person if we pay enough attention. I don't think we've had a person dying from oxygenation failure in our medical service in the last 12 months. Most of the time they'll die from septic shock or something else. So it is possible to oxygenate. So the chief from Vanderbilt comes to check on us every few months. Last time he was here last month, he said the best thing is to do the common things, do them right, do them without mistake. And that's kind of where everybody fails from time to time. I can leave it here in the computer if anybody's interested. A ventilator is really easy. I have a couple of presentations on APRV and oscillation. I'll be happy to leave it here. If not, Ted has them in the computer in MICU. If you put them on a pin drive, look at it. You guys are a smart group of people. If you look at it, then you're not dependent on a therapist or a resident or somebody else. It's really, really easy technology.
Any other questions for Dr. Shome? Okay, thank you, Dr. Shome.
You're welcome.